Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. We are presently covering the economics of health system. This lecture is in continuation with the previous lecture. As I already mentioned, we have been discussing the health system and especially from the perspective of revenue and how funds are actually generated for a better health system. We have mentioned that tax and social health insurance scheme considered to be the better practices across the globe. And out of that, in our previous lecture, we emphasized the social health insurance and the incidence or the burden, who is sharing the burden of those social health insurance. Now, the assessment of all these things are made through the 5 important criteria. We have already discussed in the previous lecture on acceptability and transparency. Also, we discussed stability. The stability of the sources of insurance, especially for health insurance, we explained through demand and supply framework. We explained through marginal value of labor and supply of labor. This is what is the case, where we said that the implications on the employee or the employer is different. Worker or the employer is different. It depends on the elasticity of demand and supply. And in usual case, I mentioned that the elasticity of supply curve really matters, and then the shift of the supply curve for the labor is rarely the case unless there is a robust health system. Especially in the previous lecture, we concluded with this direction, where we mentioned that when health system itself improved from point A to point B or from one period to another period, so the labor supply will be shifted towards right, and hence the contribution of the worker also increases, whereas the contribution of the employer actually decreases. And this is what is explained in this diagram once again. We not only explain the change of the supply curve due to better health system, we also discuss the change due to the change in the marginal productivity of labor, or due to the change in the demand for labor is due to the cost of insurance. Okay. And our focus here is to understand whether the health system is stable due to these kind of changes. Yes, it is considered to be stable in another equilibrium point. We will reach at another equilibrium point for sure. However, the new equilibrium point will be attained. In between there are some distortions. Yes, this distortion is actually differentiating the impact to the different parties. The load, you can easily see, is different to the worker and is different to the employer. And also the implication is visible in terms of employment. Alright, so this is what we already discussed in the previous lecture. Now we are discussing the third criteria of measuring or understanding the insurance schemes, health, to define a better health system. Third one is called cost control. So, social health systems have faster expenditure growth than tax funded system. We are trying to compare also which one is better in which perspective. Social health insurance system have faster expenditure growth than tax funded system. In recent years, the mix of financing mechanism within each system has become increasingly complex. A contract or third party payer model contains more pressures for higher cost than an integrated one, both to provide more care per patient and to allow the prices of health sector resources to increase. Social insurance organizations have some role in suggesting increases in premium rates also, and in the absence of competition for customers, they have little incentive to keep rates low. There are also reasons why contract models might reduce cost. A shift from providing budgets to hospital to funding them on the basis of workload might be expected to introduce more information on cost and efficiency, and this could reduce cost as well. Okay. And so, in new public management, especially for healthcare reforms, provision of services is separated from funding and commissioning. It is really difficult to conclude whether or not the higher level of resources allocated to the health sector as a whole in social insurance system is more or less allocatively efficient than the lower level associated with the tax based funding. So, it is really difficult indeed to conclude. Higher prices encourage more resources to be applied to health sector ends, and this does have efficiency implications that are context specific. To example in these two specific cases, that where doctors are highly paid relative to other professions, more young people may be expected to train as doctors, and an oversupply of doctors could develop since they are highly paid. Doctors may carry out activities undertaken by nurses in some countries, suggesting a suboptimal skill mix in the sector. So, we are also discussing all those possibilities to address how the cost can be controlled. Now, another criteria of measurement of or assess these schemes is to administrative cost. So, the which involves more controls or administrative cost, whether the tax based or the social insurance cost based model. Collection of healthcare resources through the general tax system controls administrative cost by using an existing revenue generation mechanism. For the social health insurance mechanism or administrative costs are influenced by the number of social health insurance funds that are established. There are two papers we are citing at this moment by Thomas et al. 2006 and another work of them in 2010. They discuss about multiple social insurance fund that has led to additional administrative costs, of course, and it has also risk system of risk equalization, and it is also required to equalize and to compensate fund that attracts more expensive members as well. In another paper they discuss about single buyer arrangements. In that case they said single buyer arrangements have operated even in the context of multiple social insurance funds. The most important example cited for this case is Germany. So, another directions to this administrative cost issue is through monopsony. The monopsony buying status of the public body responsible for pooling and allocating tax resources, also in the work of Thomas 2010 mentioned this. This allows a higher level of control over what is provided and at what cost, if it is if the power is with monopsony power is attached with the public body. So, risk equalization system requires complex arrangements to avoid exploitations of loopholes in the system, to appropriately share risk across the insurance funds, and can be expensive. So, to have a better system, user incentive is must. users incentives, without that the efficiency is lost somewhere. The way people pay for their medical treatment impacts their desire for medical care or their incentive to use medical services. Resources collected from individuals via tax or social health insurance mechanism involve prepayments which are made by individuals, such as tax laws, contribution rates, etc., and they are not linked to the use of healthcare. See, prepayment is already there, but the realization is made after certain time. So, it is not really guaranteeing the strong incentive for the better quality care. By removing the link between payment for healthcare and use of healthcare, these two financing mechanisms have less influence on payments healthcare utilization decision. Then if the patient is required to pay for healthcare at the point of use. So, basically we are trying to say the point of use is more guaranteed the quality than that of the prepayment. Okay. You can check with prepayment and prepayment and point of payment. In fact, there is a risk of moral hazard whereby people may change their behavior when not faced with paying at the point of use. So, basically moral hazard problems tells that there might be overutilization of healthcare services when it is considered with prepayment. Okay. And when somebody is paying the fees, there are different reflection of behavior. So, accordingly different models are designed. Now, we are discussing equity. Equity is also part of the assessment. Equity issues arises from the division between what people pay for the healthcare and what they actually receive. That payment may be through taxes and health insurance. And now that is again dependent on the ability to pay and according to the need, whether the delivery is actually according to the need. There is cross subsidization from richer people to poorer people as well, from healthier people to sick people, and accordingly equity is addressed with a progressive payment, and not only do richer people pay more than the poorer people, but they pay higher proportion of their income relative to lower income people. For equity, payment has focused on adherence to the principle that payments align with the ability to pay. A progressive payment, not only do richer people pay more than the other, they also pay higher proportion of income to the other category. The mix of taxes and the structure of taxes determine how progressive and the total tax contributions are. So, accordingly we can understand whether high income category or the low income category is actually contributing better. Cross country analysis shows that social health insurance systems are less progressive, and in practice then tax based systems. So, across countries, Wagstaff et al. Derive that actually this is less social health insurance system is less progressive than tax based system. Another criteria is called rationing of services. The services that is rationed is through different categories. Regardless of how funds for healthcare are raised, certain rationing in the rationing is made as per the priority of the access to guarantee the dealing and guaranteeing the service. So that is either through public taxes or social insurance schemes. So there are certain indicators of the rationings, especially setting the pattern of supply, gatekeeping, waiting list and queues. Okay. We will discuss one by one. Price mechanism is considered to be considered to be a poor allocator. Price mechanism is a poor allocator of resources in the health sector, because maybe the other end of the section may be the burden. In most nations, rationing is done through waiting list, line-ups, gatekeeping, service planning, user charges, etc. Additionally, also they interfere in the market to help the poor, and hence there will be issues of equity as well. So, setting the pattern of supply and the supply pattern determines the access cost, and also supply pattern level at which other rationing mechanism are applied is very important to discuss. Setting the supply pattern requires more difficult decisions in most healthcare system, and resources are insufficient to meet the vast range of valid requests that they must address. Under the tax based healthcare system of especially in developing nations, millions of women cannot access routine and indisputably high priority health services such as the ability to perform complex birth by cesarean section, etc. Okay. In developing nations, all users of resources have extremely high opportunity cost. It is not easy to allocate where resources could be found to staff and equip operating theatres in remote and sparse populated regions. Hence, such issues show poor decision making in terms of maintaining optimal financing levels and setting supply patterns. The pattern of social or tax finance health insurance should aim to regulate demands for health resources according to their marginal social value. Another category as part of this of rationing is called gatekeeping. In that case, referral system is mostly referred. The most tax finance system which we already discussed attempts to use gatekeeping, that is through referral system, to ration services to those with the highest priority demands. In UK particularly, the whole population should be registered on the list of a general practitioner, that is GP. In all cases other than emergencies as the first point of contact with the health system. Whenever a case falls outside the GP or requires specialist facilities, the GP refer the patient to an appropriate provider. This process ensures that specialist and referral services are rationed towards appropriate demands and needs should be made. Two findings from two different authors we have mentioned. Problem is that in one author derived the clinical, economic and ethical implications of gatekeeping, and the mechanism has worked imperfectly, that is not perfectly functioning. And the varying rates of referral and large number of patients as identified in Wilkin and 1989 paper directly attend accident and emergency departments for minor complaints that could be dealt with by the GP. If the price mechanism were used, had it been with the price mechanism, patient's own assessment of need for specialist services weighed against higher price, paying a generalist for advice and then paying services recommended. And in that case, and this involves even dual burden as well. So, not just for assessment that need specialist services, but also the services they are further paying, and first of all generalist advice as well as paying for the services, both way they require price to be paid. Hence, it is attached with a dual burden. Most patients made choices between specialists based on lay advice rather than professional advice. There are authors who have worked and identified the problems, especially in US case we have mentioned, and even in another paper identified the issue in the context of Russian Federation. Waiting list is another way where of rationing mechanism. Administered quick queues are important by which patients refer to departments where unavailable services are listed and allocated the resources and it becomes available in order of registration on the list. This does not prioritize higher value demands. The highest value should be placed on the demand of the potential patient who has waited for more time. Okay. So, it is actually not differentiating by the price which I have already said. Waiting list adopts prioritizing mechanism, emergency are prioritized and sometimes also numerical scaling or priorities proposed as discussed in this paper. Please note that all cases receiving the same weight on the list have the same priority, and that weighting is a fair means of rationing among cases of equal social value. Even there are some other observation, like in terms of elasticity of demand, some estimates found that it is of the waiting time elasticity of demand is minus 0.5 for English cataract patient in 2000. And another example, waiting list and the demand and supply side approaches based in UK, you can just follow on your own. Long waiting lists are evidencing and of themselves of poor resource allocation to the health sector and rationing within it. So, it also involves opportunity cost because of long waiting, and especially in the paper 2013 reviewed waiting list policies across 13 OECD countries. The most implemented policies specifying maximum waiting time guarantees, that is one of the solutions also for a better health system. The conditions for long waiting list are of low scientific interest, okay, and that may also distort the health system. The consultants also use waiting list as a signal for their reputations with patients and general practitioners, creating the incentive to maintain them unnecessarily. There is inevitable inefficiency in using waiting lists, especially in the case of chronic disease. By making elderly people wait for treatment, it may be reducing the overall benefits associated with the given operation of treatment. So, waiting list, and another one is called queues. So, more the queues is there, so expectation is higher for waiting. The next rationing mechanism is due to QE, in which patients physically wait to receive services. This is in fact called queue, means they are physically waiting, and queue is rationed based on the patient's willingness to allocate time. It's dependent on the patient's willingness. There is a strong relationship between such willingness and the social value of the services. And one note here we have given that it is sometimes argued that higher social value should be placed on the receipt of services by breadwinners, as I already mentioned with the case of willingness in case of QEs, or mothers whom the rest of the family rely. Such people are likely to place a higher value on time and be least able to spend long hours queuing. Physically waiting is considered to be a cost for them. Triage is another one, the system of triage by which a nurse or doctor quickly assesses the emergency situation and prioritize the situation for the better health system, and accordingly the queues can be redressed. Inefficient and inappropriate rationing mechanism, where its use is often means of maximizing the efficiency with which health professional time is used rather than the ration services. In extreme emergency, waiting cannot cannot be a rationing mechanism. Supply restraints are absolute. Gatekeeping assumes critical importance when it is of extreme emergency. So, also please go through this example, especially in the emergency case, organ transplant, etc. We have discussed. Now, we last couple of slides to understand the difference between rationing mechanism and social health insurance scheme. Social health insurance tend to make greater use of co-payments than do tax funded system, thereby relatively emphasizing private rather than social demand. Especially in Germany case, out of pocket payments grow significantly between 1995 and 2011, and as a share of their total expenditure. The co-payments within the social health system are not the major type of out of pocket payments. They are only about 1/7 of the total out of pocket spending. Co-payments have been also increased in Germany's health reform since 1990. This increases the role of price based rationing when we are issues of co-payments. The effects of that are mitigated by the exemption of those under 18 years of age, and for most services, pregnant women, etc., the poor, and the people with substantial health needs. There are some other example we have cited for French social health insurance scheme with 90% of the population is covered under BHI scheme, okay, and that's which protects them from these payments, reducing the extent of price based rationing in this BHI scheme. So, another we have also mentioned in terms of equity implications and information related inefficiencies, please have a read. And we cited 2015 paper of Chevreul discussing about additional co-payment issues. Please have a look, and I am sure it will be understood to you. So, now I am going to summarize all these things and clarify what is all we discussed. We try to discuss and assess the social tax and social insurance mechanisms for a robust health system. We emphasize all those indicators. We try to derive the differences. Many differences are in fact due to how the mechanisms have been implemented in different health systems, and some objective may be easier to achieve with one mechanism over another. Transparency in social health insurance cost control is easier with the tax mechanism. Tax mechanism concerns the lack of instrument to push funding towards appropriate levels, weaknesses in the applications of rationing mechanism, difficulties in managing incentive that promote performance improvement, especially where public sector capacity is weak. So, these are all we discuss, and you can in short how health system can be improved, whether it is price mechanism method, rationing method, or through other approaches which different other rationing method we discussed, so that private out of pocket expenditure could be lower. And we also compare these two models, and there are many strengths and weaknesses we identified of both the model, that is tax and social health insurance mechanism, in terms of their acceptability, transparency, stability and cost control. Resources are rationed to the highest priority, and with social welfare maximizing target through some of the rationing approaches through gatekeeping, setting supply of services, waiting list queues and others. Now, in order to read, since this is theoretically discussed largely all the points, I think reading is must. Two readings we have cited, it will be useful. These are the latest two readings we have followed. In the next lecture, we will be discussing on private financing mechanism and also on assessment of out of pocket payment mechanism and BHI schemes, etc. With this, I should stop here. Looking forward to your participation. Thank you.